To begin with, we don't have a moderator for this chat, so I'm going to do the moderator part as well as join in. But to begin with, I would like to see if Dr. Martin, what would you share and how would you think that how could we improve service and value if we reduce readmissions? Because recent research have shown that the readmission reduction program is not really improving value. I'm sure you must have read that. So how are we actually proving that wrong, and what's going to be the take for the audience here?
Well, I think, is that on? I think that the value really comes from keeping people well and healthy. You know, everything we do at Geisinger nowadays is about keeping people healthy. Readmissions, you know, although important, we hope is a secondary to keeping them healthy. We keep them on their feet, keep them out of the emergency room, maintain access to our primary care departments particularly, you know, is really the key. And if we're going to succeed in this, I mean, we need to succeed in those three efforts.
Great. Thank you, Dr. Martin. Dr. Ward, what would you say about the improving service and value?
Yes, I agree that the kind of addressing the upfront preventative is certainly a focus of Kaiser Permanente and Permanente Healthcare as well, and having our physicians engaged in that from the very beginning. You know, I also think that we tend to look at a readmission as some type of failure of the system. It's rework, it's where something went wrong. Right. And so using our systems to go back and really understand and examine why we had a failure in the system and directing initiatives upstream to prevent those failures as we move forward. And then finally, I think for the times that we are not able to intervene on chronic disease and complicated combinations of conditions that our first presenter certainly talked about, when you see 6 or more chronic comorbid states where you do see this high readmission population, how do we engage specialty providers and our primary care doctors in the actual management post a readmission event as an active part of the management of the transitions process, and not just guiding them on a transitions pathway, but actually more of an involved management perspective from the provider's vantage point.
So to that point, you know, at Geisinger we had a very robust patient-centered medical home program that we started way back in 2005. That involved our primary care practices. And at that time, we had about 55 or 60 primary care practices. And we did very well. We met our metrics. We had quality metrics and cost metrics and patient experience metrics. And we had a lot of engagement by all of our providers in community medicine. We tapped the brains of some of our specialty groups, so endocrinology for our diabetic quality program, right? Vascular surgery and cardiology for some other quality measures, but we didn't include them in the actual operation of the program. We changed CEOs about 5 years ago, and the first thing that happened was that community medicine was not its own service line anymore. It was moved into the Medicine Institute. And those of us that were leaders in community medicine, you know, weren't real happy with that at first. But after 5 years of it, we now are implementing we now call it practice design or practice redesign, but all the elements of practice design and care delivery now are being introduced into the specialty practices of endocrinology, renal disease, rheumatology, and other outpatient medical practices in the Medicine Institute. That has made a difference in access for our patients and maintaining them well. The other thing that I'll say has been one of our real challenges around readmissions is getting the patients to call. You know, everybody has initiatives out there to our patients. Please call before you go to the emergency room. You know, and when I was a chief resident, which goes back to the early 1980s, one of my projects was communicating with the patients in our family practice to call us first before they'd go to the emergency room. So this has been a career-long initiative for me to get people to call before they just show up at the emergency room. And it's still, I mean, you know, those of you that have that problem, I mean, it's really a challenge for us. So I don't know how you manage that at Kaiser.
Yeah, so we've actually had, locally in the Georgia region for Kaiser Permanente, we had an initiative that deployed about 4 or 5 years ago, where we have kind of freestanding acute care CDU type centers that have emergency medicine staffing, but really are under the purview of all of our internalized integrated systems. And it took a lot of patient education, But what we've seen is there are certain ways to drive that behavior back into the system as opposed to an ED or a hospital ahead of time, so that we can actually start the upstream process that would even get ahead of the entire admission and transition via using those types of facilities. And it's a little more difficult if you don't have something that feels like an acute entry point to just get them to call and come in. But for us, that's been a successful way to approach initiation into the acute care system.
Yeah.
That's great. That's a great point. I'm just going to add something there is, if you haven't done this at your institution, readmission is not a project, it's a process. Dr. Martin actually mentioned that one of the causes of readmission you will see is communication. We did about 146 RCAs, what is also called root cause analysis. I would highly recommend for you guys to actually do a sample RCA on your readmissions. You will actually find out what exactly the problem is. Most of the time, 98% of the time, you're going to find out it's not a clinical issue. It's actually more compliance, communication, and escalation issue that we are talking about. So certainly try to implement there. The next topic I think I would like to address more towards is readmissions is certainly a topic we need to focus on, but at the same time, we need to focus on the quality of care. You talked about PCMH, level 3 PCMH. Same as my institution, we attained level 3 PCMH for like 13 different sites. We had a lot of kudos and awards and recognition and stuff, but did we actually improve quality? What would you say Geisinger's take is on how does quality get impacted when we actually focus on these initiatives?
Yeah, well, I mean, all of our processes and all of our care designs and workflows that we change through this redesign and design process really works toward quality. I mean, our assumption is if we improve quality, then we're going to improve care and keep people healthy. So when we talk about a new initiative or a new workflow in an office, it really starts with quality. How do we provide better care? How do we provide better disease control? What process can we change to do that? And then what's the downstream effect? How will that keep people healthier and keep them out of the hospital, out of the emergency room? So I think it's got to start with quality.
Absolutely.
Yeah, I think for us, quality is certainly the North Star of what we look at in terms of all our initiatives. I think that is one of the really strong advantages of being a value-driven healthcare organization. It's not, they're really, at least to those of us doing the work, feels like there's no perverse incentive about the decisions that we're making when they're around quality. And we have seen some really strong specific improvements in things around high-risk readmission populations and strong reductions in that particular group of people, as well as with medication adverse events and near misses on medications. We can really track that data. And we use,
so there's a direct correlation.
There's
between
direct
those
correlation
two.
that we can
Exactly.
that we can point back specifically
That's exactly
to
right.
interventions
Good,
we've chosen, and we have a host of tools that we've deployed to get us there. But again, back to the fact that yes, quality is the North Star, and I do want to make a comment on your readmission review. We have completed one this past year, actually. For those of you interested in what that can look like, our physician that developed that program's here today, and we can get you connected with him. But we've completed one, and you're absolutely right. There are insights that can be gleaned from that that are not readily available by the assumptions we make going into it.
That's certainly right. So thank you.
We have a quality dashboard that is available to each and every one of our physicians in our organization. And our methodology for communication is that sort of starts at a high level and it's cascaded down through the department directors, as our primary care groups are divided into 8 different departments by geography. And it's the department director's responsibility to communicate with each provider about their quality initiatives. But we have a daily huddle at every practice, and at the daily huddle, the current quality scores are one of the things that's addressed virtually every single day. And so it's public information to the whole practice, to all the members of the practice, the nurses, the medical assistants, the community, or the patient access reps, et cetera. So there's a little peer pressure there. Nobody wants to be the lowest on the list for whatever quality measure we're looking at. So, we really try to get everybody incorporated. So if somebody needs a mammogram, for example, the doctor doesn't have to do that. A secretary, a receptionist can actually, pen that order so that when the patient gets in to see the provider, it's already penned, and all the provider has to do is approve it. So we really kind of share that work.
I think
You brought up a very good point about quality scorecards and how do we perform a huddle based on those, the data elements that we have in there. One of the things that I have seen is that talking about readmissions and data after a month is of no use. Forget about actually reporting data scorecards after a month. My CEO gave me clear instructions saying, as a chief quality officer, your focus needs to fix quality, not report quality. So how do we do that? So we are trying to do a huddle in the emergency department with the surgeon, with the specialist, with the emergency doc and the attending when the patients get admitted. We are not going to talk to him after the readmission happens. So try to put the huddle more at the time of service. And that actually made a huge difference for us as well. You were saying something.
Yes, I think it also brings up a really important point about the interdependence between quality and operations.
Yeah.
Because if you look at some of the executive oversight and how resources get aligned depending on where you can implement your initiatives, there can be some siloing. And so really you have to bake those things together. And there's so much interdependence. The executive oversight for all of our transitions work involves both quality leadership, continuum operations, acute care operations, and that goes, again, to what you're saying. How do you address it up front with a mixed group of people that are going to provide the care as opposed to after you're addressing the rework?
True.
Yep.
So
Yeah,
true.
you can't just say order more colonoscopies as a director and expect people to order more colonoscopies. You've got to be able to change that workflow
Right.
that makes it easy and
Right,
flow
right.
easily for
Exactly.
the providers to get the work done.
That's great. So one last, the segue actually is really good to get into data. Now, how do we actually utilize data? We have heard about data, and I think we have lots of talk about data outside. You will see that as well. But is data just data for healthcare, or is data actually information for healthcare? How does Geisinger utilize data to convert it into information specifically to address this problem?
Yeah, so the short answer to that is all day long. My job now as a physician manager, and I'm also the chief medical officer for our accountable care organization. So I get lots of data, both from the Medicare fee-for-service world and our Geisinger Medicare Advantage plan. And it's really what I do all day long. I said I'm a family physician. I've actually seen patients until about a month ago. I gave up patient care at the end of the year. But many, many years I spent, and I thought that lended to my credibility as I managed folks, because I walked the walk. I not only talk the talk. It's been difficult for me to give up that patient care. But, I mean, I deal with data virtually every meeting I attend all day long now, with reports about who's doing what and how to communicate the results of those reports to get the result that we're looking for. Mm-hmm. So it's really just the way we work, and in the future it's going to.
Would you say all levels of care are involved in data? For example, a resident in the emergency department, a case manager, are they involved in the same level of data as you are?
They have access to the same level of data that we are. If a resident is seeing somebody in the emergency room and making a decision whether that person needs to be readmitted or there's another pathway, it's his or her responsibility to begin that decision process and begin that pathway.
Mm-hmm. Good. Dr. Ward, what would you say?
So I agree with all day long. We certainly have a number of reports that feed automatically to us that we can dive down into that have everything to do with how acute care environments are being utilized, how many people are in any point of the transition process, whether it's hospital, subacute nursing, rehab, LTAC, those venues. We have an opportunity to go back and look at those. We link the North Star quality outcomes metrics as effectively as we can back into the data, but really pinpointing, as anyone who in this room does readmissions work, pinpointing that single thing that's going to make a difference in an intervention, it doesn't exist. And so it's really kind of gleaning all that you can for that information as it feeds back in, and making decisions about how you're going to leverage things such as limited resources or, when you have to capacity match. Because I think we all know, and certainly the New England Journal article recently showed us that just throwing lots and lots of resources at a problem doesn't fix it. So we use data a lot to sort through the decisions made, not just on how can we fund initiatives or where we might direct them, but how we're going to resource them, how we're going to share those across the transitions environment. environment. So agreed.
Very good. I agree with that. I'm going to give a little bit of time to actually have questions from the audience. But one last question before we move on to the audience is, looking forward, let's say 3 years, 4 years from now, readmission today is 5 years prior. We will see readmission was calculated. Somewhere not paying. Today, most of them are not paying, but there are still some readmissions getting paid, as you can see that in your claim-based history. But what do you pursue further? 5 years from now, readmissions, where would it stand? Would there be an artificial intelligence robot available for, where is Geisinger going to see this coming in terms of that being a healthcare plan as well as hospital system? Where is the future heading to?
So we're beginning to move forward with video visits and telehealth. And we actually have some specialties that are using video visits now for follow-up. So elective joint replacement patients who are medically stable are eligible for a video visit by the orthopedist. Neurological surgery does the same. We have video visits in pulmonary and behavioral health. Cardiology is getting into it. And I think that that's going to grow and blossom. I think, when I first thought about video visits, so one of the other things that I do is manage our network of urgent care centers. So we have 22 urgent care centers. And my dream a few years ago was that we would have a video booth in each urgent care center, so when the waiting room was full, people would have the option to move into the video booth and get a video visit. Well, that didn't happen mostly because of space constraints and other hierarchical issues in the Geisinger system for those dollars. But as the specialties now get into that, I think that really is a wave of the future. We have a movement specialist neurologist at Geisinger now who only operates via televisits. He lives in Altoona or somewhere remote from our hospitals and our clinics, works from home. We have an endocrinologist that does the same. We are just now beginning to look at direct-to-consumer primary care visits, although my dream a few years ago was that we'd get into that in a big way, but when you really think of the applications of that, there's not a whole lot of conditions that are going to be amenable, I don't think. But I think specialty to primary care, video health, and specialty to the consumer video health is probably where it's going to go, and that incorporated with AI. We have a new innovations department at Geisinger that is really getting into AI in a big way. NLP for data extraction, and other things along those lines.
It's pretty impressive to actually hear those words coming from an MD, NLP, artificial. It's pretty cool. All right,
the data part. It's the data
absolutely.
Part.
It just excites us.
So I think all aspects of virtual care. I mean, I think the innovative side of what technology is going to bring to medicine, because sometimes I think we're slow to try to bring things forward, is really where we're going to see opportunities. It's, a part of people who use their watch for all of their, physical metric downloads where we can monitor their blood sugars and their vitals and things like that. We have, some of our departments are incredibly strong in interactive virtual visits, the IVVs that we call. And so we have a whole host of virtual opportunities where we are starting chat with an MD, so you can actually chat online for certain low-level triage conditions. The video visits, we have kind of a system where we can do KP Now, where we can triage a low-level visit quickly to actually get a doctor on the phone within a specified amount of time. So I think some of it's kind of triaging a certain level of health care to ways where we don't have to use brick and mortar to help people. And I think not just within the Geisinger or Permanente systems, but I think nationally, especially given our introductory speaker, if I look at rural areas of Georgia, many of those areas for the insurance, 65% of those are CMS-based care, and then the next majority is that they're uninsured. And so those areas may have some primary care support, but they don't have any specialty care support. So as we perfect them within our larger systems and really understand how these work, how can we then spread those out to underserved communities and represent specialty care via virtual visits and really capitalize on some opportunities for healthcare nationally?
No, that's a great point. Yes, Dr.
Likewise, I'd say Geisinger, geographically cuts a swath through northeastern through south central Pennsylvania. Not Philadelphia, not Pittsburgh, not Erie, but the rural and relatively underserved part of the state. And so these issues, with remote access and that sort of thing are really playing a much greater role for us. The other thing that I'll mention that, that kind of surprised me as a family doc, but I learned recently that in our innovations department, we actually have what they call a nudge unit. Does anybody know what a nudge unit is? So, yes, I saw one hand down there.
Yeah.
So this is a group of behavioral psychologists, now not behavioral health, but behavioral psychologists that work to help us to nudge people to do the right thing. So those folks that won't get their flu shot, or those folks that resist their colonoscopy or their mammogram or whatever advice we have for them, that we know it's the right thing for them to do, we hope that these folks will develop some practices and protocols and education for the rank and file providers that we can use to nudge these people to do the right thing for themselves. So that's kind of how far
That's
we're
really
going
interesting. I'd like
Yeah,
to
that's
see
a really
data on how
interesting
they,
topic.
yeah, how
So
they do.
I think in data, the biggest part of data is we have all kinds of clinical data, financial data, but we don't have the behavioral data. And I think that's where one of the biggest players that I feel like is going to be key is Amazon. Because Amazon has the Whole Foods, Amazon have Prime, Amazon knows what we shop, where we eat, what we do. So they are going to be capturing more behavioral data and seeing that. So with having said that, let's turn it over to the audience and let's see if we have any questions from the audience for the experts here. And Brian has the microphone, so he's going to bring it to you guys as soon as, right there.
I think that the virtual visits are absolutely a fabulous idea, but I'm really concerned that we talk about the underserved in the rural areas. Those are the areas that don't have the internet very much. So how do you address that?
Well, one thing that we do, and we service mostly just the metro Atlanta and greater area from Kaiser Permanente, but we still have pockets of patients that are on the border of Alabama or South Carolina that are from more rural areas. And typically most of our virtual visits can be done with no additional technology beyond a smartphone. And I understand not everybody has one, but that is becoming a more common item for people to have. But then the second option is if they can't make it all the way into one of our specialty centers where our largest collection of higher-end specialists may be practicing. We do have some more remote outlying smaller practice buildings that might be close for them, and we can actually set them up in an office environment where we're providing the technology and then they can have the visit. And so their distance is less and we provide the technology to support them.
So we basically developed a new model of practice to reach that population. Our health plan recognized that there were several thousand participants for whom they got hospital claims or emergency room claims, but never a primary care or specialty outpatient claim. So they'd go to the hospital, they'd go to a nursing home, get rehab, go back home, and keep recycling. So we developed a program that we call Geisinger at Home, and it is administered regionally. Geisinger kind of divides itself into the west, central, and eastern regions across the state. And we have physicians, nurse practitioners, nurses, community health associates, care managers, pharmacists that are all in this program that will actually go to these folks' home if they allow us, and most of them do once they get to know us. If there's no internet access where they live, they take a jetpack so that they can actually communicate electronically with our electronic record system. And so far, I think that they've enrolled about 5,000 patients in Geisinger at Home over 2 years. So we're trying to get out to those folks. Yeah.
In upstate New York, actually, we can't go more rural. I'm not kidding. I mean, we have a hospital where there is nothing, literally. Like if there is a Walmart, like, oh, that's a celebration. So I think there is a lot of dead spots, networks that are not available. Jetpack is one solution. And then another feature that I had a privilege to work with an endocrinologist to implement some of the virtual endocrinology visits, and they created the churches as their hub spots. So the churches were actually where the patients used to go. Like they used to get like a weekend kind of a treatment plan there and stuff like that. So that started taking place as common public places could be powered, and then they can get over there. I think we have another question, but thank you. think we have another question. We'll come back to you.
Hi, Fahad Rahman with Lumi Health. Rick, thanks for the feedback. Obviously, a lot of this resonates with some of the work that we used to do in the past with you. The question is, how have your organizations, I think they're both well known for technology, using technology assets, not only to identify where opportunities exist in the population, but also to execute interventions and organize care, especially in the outpatient care continuum. So it might be helpful to understand what that looks like today for your organizations, and then as you think about the future of more and more use of multidisciplinary care teams, various different care vectors like telehealth and so on and so forth, how do you rationalize those decisions, and what role does technology play in actually implementing the interventions as opposed to just using analytics or dashboards to identify where the opportunity exists, if that makes sense?
Yeah, good question, Fahad. Thank you. So we've developed what we call an AMP report, Anticipatory Management Report, that is available every day in every practice for every provider. It's also available in our electronic medical record. So when we're in the chart, we can click on the AMP report tab, and that basically gives us a distribution of care gaps, a care gap analysis. It also gives us some advice on some disease-specific metrics that our providers need to act on that haven't been acted on. Mm-hmm. And so it's expected that with every visit, that the providers go into the AMP report and determine, what's to be done and what's not to be done. Then in the background, we have a best practice team that's continually doing data dives into our EHRs and determining, what our opportunities are and what our care gaps are. So for example, if, by July of this year, they take a look at colonoscopy orders or mammogram orders and we're sort of behind the curve, then they will develop an initiative. Again, it starts with a workflow that can be relatively easy for the provider. It can't provide a lot of extra clicks and work for the providers, but they will develop a workflow for that specific deficiency so that we can achieve better results. Our diabetics, for example, diabetics with an A1C greater than 9, our providers will all get a best practice alert and a defaulted order for our MTM pharmacist to work with them around their medications. So it'll start with the identification of a deficiency or an opportunity. It's brainstormed for a long time, and we need to make sure it's also vetted through our providers. They're going to have to be doing the work, and then we decide on a workflow to be able to close that gap and provide that benefit to our patients.
Yeah, ours is very similar. We have automatic best practice alerts and things that we'll fire when there are care gaps. We have workflows that are distinctly separate where nursing can address those as well in penned orders. And then physicians have opportunities, and then there are missed opportunity reports where physicians can go back and see by department, and you can drill down to individual providers. So certainly we message to our chiefs a lot if it looks like we are having difficulty getting flu shots or mammograms, or there are areas where we're really dipping below quality metrics that we track in those specific areas. I think another thing we're starting to work a little bit more with is predictive analytics and seeing how far we can pre-identify these populations. I know that my readmissions team that is here today has done a lot of work in that recently and validated that against other risk stratification tools that people routinely use, like ACE and LACE or segmentation. And so we're really trying to push that a little bit further with predictive analytics and understanding where we identify certain populations well ahead of the game, and then being able to talk about what interventions may look like, again, with best practice or other things where we can get in on the front end.
Yeah, I think that's a great point Dr. Ward made, is data analytics is actually like 10 years. Now we are looking at more predictive analytics. We need to focus on what's going to come. So I think what's LACE was used 20 years ago. That was great. And then hospitals started using modified LACE, and then modified LACE 2 and version 5 and all that stuff came in. But now organizations are already predicting on multiple factors of that patient, 18, 20 variables that are being considered. Mm-hmm. So how do you use analytics to focus on certain area or certain population? So that's, I think, where we're heading to. I think we have a question here, Brian. Okay. He's going to come back to you, sorry.
I got dibs. Wichita Lang, Novo Nordisk. Question for Dr. Martin. You mentioned the nudge unit, and I just read the book by Richard Thaler, Nudge, but are you able to speak about the focus areas that the nudge unit at Geisinger is working on and kind of the effectiveness of that unit?
Honestly, I can't. All I know is that there is one. I'm working on a project around readmissions with some of our orthopedists. We have not yet had our first meeting with the nudge unit yet. That's scheduled for when I get back home next week, actually. Sorry about that.
My question is to Anu. So you want to handle the readmission problem at the time of the admission. So you go down there and talk to the doctors and the nurses. What do you talk to them?
So I think the goal is to not prevent the readmission, but the goal is to actually prevent the next admission. So we have a predictive analytics tool like Dr. Ward mentioned that our readmission team has actually developed. The readmission scoring is based on a transition care home approach. So the scoring methodology automatically says 98% confidence that the patient is going to come back in 2 days. So who calls the patient? So is the nurse who calls the patient, the case manager, or the home care team? So we kind of trigger those things ahead of time. If the patient still shows up in the ED, then the provider actually comes into the picture and sees that how we could prevent the next admission. We are not trying to prevent the admission that is actually on hand. So the focus is more on the preventive side of it rather than the reactive side of it. And that's where we need to head towards, that is the preventive side. We've been very successful with that, actually.
And the
But
question,
do you know that the reason we have this readmission problem, is because in the hospital, the system of taking care of the acute medical problem is such that there is no intent to treat that problem.
So I can
Please try
comment.
to understand that if you go and ask a CEO of a hospital who is running acute care system, he will tell him to the medical staff, wait, the reason we have people admitted in the hospital is so that we can diagnose what is the matter and plan the treatment.
Absolutely.
And then execute their plan elsewhere.
Yes,
Yeah, I agree.
agreed.
Got it?
Yes.
Now the people who are therefore designing the cause are different, and the people who are executing the plan are different.
So I think that's where we need to
So,
bridge that.
yeah,
So Dr.
so-
Ward,
That's right. Unless
Yes.
you
yeah,
So-
we need to bridge that.
So we have a very robust kind of cultural piece of our program that starts right exactly when you identified at the time of admission, where we really talk about the long view care plan. And so the acute problem, yes, may require elements in the hospital to diagnose or stabilize, but you're right, that is not in and itself separate from that patient moving forward. And so our conversations are really meant to be centered around what is the long view care plan that encompasses the next 6 months
Yes, exactly.
down the road for this patient, and they should not be discharged until everybody on the team is well-versed and been able to contribute to what the long view care plan is. And whether you use acronyms like NECTAR or things that address nutrition, transportation, caregiving, mobility, all of those things that
Medication
are
adherence.
medication adherence, all those things that are required elements, but you also have to
Absolutely.
include the provider on that front to say, this is
Absolutely.
the expected trajectory of the medical history of what's going to happen with this patient's particular prognosis. And if it involves people that are not necessarily there, specialists, outpatients, things like that, then we really engage in warm handoffs. Because again, you have to be able to relay that long view care plan with a very integrated system so that it's not just, we fixed your problem, now you go, and now that you're out, then we start transitions. Because that will never prevent a readmission, just as you
Right.
pointed
Yep,
out.
I agree. So I remember not too many years ago, the transition to care and readmission planning was easy. Because as a family doctor, I just did it all. When I was discharging somebody from the hospital, right, it was my responsibility. Well, that's all changed and everything is all fragmented now. But we likewise have a very robust process.
Right.
We have inpatient case managers that are assigned to patients the day that they're admitted and will stay with them through their hospitalization. The expectation is that they will communicate with the office-based embedded case manager at the time of discharge. Our hospitalists are expected to tiger text and communicate with the primary care physician in the office at the day of discharge. We have pharmacists, inpatient and outpatient, which will communicate with each other, and even nutritionists, when appropriate, will make warm handoffs. So that we're trying to do a better job with that transition and handing those patients off from inpatient to outpatient and maintaining that care plan that you so accurately described.
Sorry to interrupt, but go ahead. And then we'll come to you.
Hello, my name's Jenny. I'm from Sibley Memorial Hospital in DC. And thank you for this really interesting information that you're sharing with us today. The question I have is, we're actually in the process of looking at telemedicine for our stroke patients that go home, especially if they have mobility issues and having a really hard time getting back to the hospital. But being in the district, we've got Virginia, Maryland, and then the doctors are licensed in DC. How do we work with that situation if they've only got a license and to practice in the district?
A cross-state licensing
yeah,
issue.
so is that something that you might have information?
We don't have that problem, so I want to make sure that.
So I'm going to actually call a friend here. Geisinger's director of telehealth.
I didn't know that was an option.
Geisinger's director of telehealth is actually in the back of the room, and I'm going to ask Tejal if she would kindly respond. I have not been aware of that. Have we encountered that?
I haven't either.
Thanks for putting me on the spot here. But he did prep me.
You're the expert.
No, we actually have encountered that, and honestly, the only way we've been able to deliver care to patients, our patients in New Jersey, is to get our providers licensed in the other state. That's essentially the only way to do it today.
Yeah.
There are talks about cross-licensure protocols and agreements, but I think that's probably about 4 or 5 years down the line before we see any of that come to fruition.
I would also like to point out that in organized medicine and state medical governance, different states have different regulatory policies regarding telehealth and video visits. So for example, in Georgia right now, the Medical Board of Georgia has issues on their table that are related to how telehealth can most effectively work.
Absolutely.
So even though you may be able to generate licensing in an adjacent state, you would still potentially need to address the medical board and or state legislation and regulatory processes in those areas to make sure that the telehealth was not in violation of anything or put the patient or doctor at risk in any way.
I agree.
And
We'll
that's a
take
great
one more question.
And as Geisinger continues to expand northward toward the New York border, and so patients will migrate, from New York to some of our practices. So that's actually a great question for us. It's not just our New Jersey partnership, but people who will migrate in from other states. Yeah.
I think we have a question right there. Yes.
Thank you for the presentation. It's definitely been very helpful. My question is actually related to, we've talked a lot about how you want to predict what patients are going to readmit. I actually represent a safety net hospital, and many of our patients have social issues that actually drive them back to our system. Could any of you just explore what you have done to date to really address those issues? Because many times the issue is not medical.
Right.
It's truly a social issue.
Right.
Yeah, I'll take that question to begin with, and then I'll have Dr. Ward and Dr. Martin join in. But so I don't know whether you have done the history. I think you must have pulled up my LinkedIn account, what area I work in. But I see some of the colleagues here actually who are in my area. The income in our area is $18,500 annual income. You cannot even imagine like these populations who are actually have a lot of social issues, and how are we going to keep these patients? So we had a patient who actually recently in 2019 came back to the ED 140 times and 68 times admission. Looking into it, there's no air conditioning at home, so he actually utilized air conditioning. There is no food to be put on the table at home, so we tried to do those things. So I think the connecting with the community agencies, because we cannot do it all. We can't do everything. We can't provide treatment. We can't remodel their bathroom because he was actually, his bathroom was clogged, so he was utilizing his living room as his bathroom. So I think we cannot do it all, so that's where the connect piece comes in. and the care coordination piece comes in. So we started, in our readmission meeting, we actually have the community home health agency actually do it. So all our readmission alerts not only just stay within the hospital anymore. We send them to home health agencies, we send them to home care agencies. So they have these grants that they could remodel their homes and stuff. So I think there is a lot of opportunity out there. There's funding available, but you have to connect the dots and do that. So we have attempted that, and that have worked, I won't say extremely well, but certainly has helped us. I want to see if Dr. Ward or Dr. Martin wants to add something.
Yeah, I mean, I think we've all seen patients where the home social situations really help us start to understand why there's heavy utilization of healthcare services. And you're right, as much as you want to go the extra mile, especially when you're partnered health plan systems, you can't solve that for everyone out there. So you leverage the community as heavily as you possibly can. You make sure that your touches that patient's having with your system are on the high end with social work, with case management, that all those resources are well defined and are updated. You can't just put them into place once. You really have to stay on top of those. On the other side, what we really, I think, are starting to do a lot of work in are just those social determinants of health and really looking deeper into those populations for health, for physicians and healthcare in general to figure out how to approach the larger part of that problem. Because I think we all know that healthcare and disease isn't just one specific diagnosis in many cases, and it's much more complex than that. And it isn't an easy answer. I think on a day-to-day business basis of how we function, you leverage what's out there in every way you possibly can.
So in 2013, Geisinger Health Plan became one of the 3 health plans in Pennsylvania that participated with Pennsylvania Medical Assistance. And we at first blush, we had 130,000 members join that plan. It's now about 160,000 or more. So that really, very rapidly, brought awareness of all the needs of this population. Our community health associates, or CHAs, are embedded in our practices, and they're really the backbone, at least of the initial programs here. If there is a homeless person, in the emergency room, we will dispatch a CHA from our office practice to go and meet that person and visit that person and offer whatever assistance can be offered via food pantries, via housing authority or housing programs or whatever they may need, helping them with their applications for assistance and what have you. One of the physicians in my practice in Scranton actually did a fellowship in an organization called the Camden Coalition. Anybody familiar with the Camden Coalition? So he did a fellowship there and actually in that training made house calls in homeless camps. And he's actually done that for us in Scranton to some of these folks. And we had a similar episode. We had a young diabetic in his 20s that was had, I'm going to say, about 100 ER visits over the course of a year and a number of admissions. And it took us a while, but finally we got that person engaged with a social worker in our practice, and he started coming to our practice. And this was a few years ago, and I was still doing hospital care at the time. I was wandering through the ER one day, and the ER manager asked me, "What happened? Did he die? We haven't seen him in weeks, And I'm very happy to say he didn't, but that we really had him in our practice and really got engaged. So there's ways to do it. Unfortunately, medical education, doesn't teach us what's all out there, and we need a lot of help from our social workers and folks on that end of the team.
And I think all of our larger organizations have large community benefit programs as well, where we try to offset on a much larger perspective for everybody in the community, things where we provide copay-free visits and other healthcare opportunities in terms of free clinics and things for people to be able to engage the system and have an offset at least of some of the financial burdens that they might be facing.
I agree. Before the fresh and bake, we'll take one more question. So.
Hi, Carl Schraub. I'm from Driscoll Health Plan. We're a Texas Medicaid managed care organization. I say we cover an area equivalent to North Carolina in a very rural South Texas. The part of the problem is most of you seem to come from integrated networks. We know here we have to now reach how to prevent those readmissions with a special population and parts of the health system that are not part of our health plan, for instance. And sometimes they're going out of network to specialized centers, which makes that challenging. So I know this is a pretty big question, but my question, what are some of the levers or other ways that we can try to engage with some of those health systems to try and have them to want to work with us? And very often they're not willing participants. And we understand the barriers to that, but I'd love to hear the panel's view.
Right.
Dr. Martin?
It's an excellent question, and I'm fortunate to be on the side where just with this very integrated network that I exist in is we don't see a whole lot of that. However, we certainly have Kaiser Permanente patients that end up in non-networked hospitals or with non-networked providers. And, you know, a couple of the typical things that probably most systems do, we have a very robust telephonic case management outreach process so that anytime one of our patients is in an outside facility, they are being contacted on a daily basis, either through a centralized hub with physicians or through a case management system with nurses to make sure that we're tracking what's happening with their care. We have a virtual hospital that we actually place these patients in so that we can all track what's happening with their health care. And what we've learned a little bit over time is that at least in the metro Atlanta area, the more that you're consistently there for patients and show up, you can relationship build from a lower level. Mm-hmm. So if you're talking about an executive level or organizations that may not want to participate higher up, you actually may be able to get in at a ground level where people say, hey, if this is a Kaiser patient, I know they're going to be responsive. They're used to calling every day. Absolutely, and getting information. And so you can actually potentially start to target in a different place than where you were looking as an opportunity to build relationships and to try to get those services to your members or get members back within your own network.
Right, so there's no secret sauce. I think you have to find an integrated network within your own system. Do you want to add something to
I
it?
agree. I mean, case on the day-to-day work, it's generally our case managers that will try to contact case managers from competitors. On the higher level, you know, these people don't want to participate for usually business reasons. They're competitors, you know, rates, et cetera, as you know, from a health plan. Sometimes it goes to the level of the primary care physician. Sometimes it has to get escalated to, myself or our chief medical officer for our health plan to try to get some resolution. Not an easy answer.